From the RSNA, I'm Dr. Jana Ivanidze, and this is the Radiology Imaging Cancer Podcast. This is part 2 of our 2-part episode focused on global health approaches to oncologic imaging and radiation oncology. If you haven't listened to part 1 yet, I hope you will. You can find it on our website or your podcast app of choice. Today, we will hear from Dr. Miriam Mikhail, radiologist and current staff member at the International Atomic Energy Agency, who has previously served as the RAD-8 International Liaison to the World Health Organization. We will also hear from Dr. Onyi Balogun, attending radiation oncologist at Weill Cornell, who will discuss her work focused on improving access to radiation therapy for patients with cancer in low and middle-income countries. But first, a message from the RSNA. Make plans to join us at RSNA 2020. Virtually connect with colleagues and industry partners. Explore RSNA's first ever digital exhibition floor and AI showcase, and access more than 350 hours of the latest science and education from every subspecialty. All RSNA members get free premium access to RSNA 2020, which includes CME opportunities, on-demand programming, and extended access to meeting content through April 2021. Register now at rsna.org/annual-meeting.
Hi, everyone. This is Nikita Consul from RSNA's Radiology Imaging Cancer, serving as trainee deputy editor on the editorial board. While I am originally from Michigan, I did my undergraduate and medical training in the East Coast, and now I'm a radiology resident at Baylor College of Medicine in Houston, Texas. My research has predominantly focused on cancer biology and cancer imaging, which led to my work with the radiology imaging cancer team. I have with me today Dr. Miriam Mikhail Lette, an initiator of the Lancet Oncology Journal's Commission on Cancer Imaging, focused on low and middle income countries, and is now a diagnostic radiologist for the International Atomic Energy Agency, or IAEA, section of Nuclear Medicine and Diagnostic Imaging, Division of Human Health, Department of Nuclear Sciences and Applications. Actually, when I was a medical student at Columbia University College of Physicians and Surgeons in 2017, I had the privilege of volunteering through RAD-8 International and working under the mentorship of Dr. Mikhail Lette at the World Health Organization's annual Global Forum on Medical Devices. At the time, Dr. Mikhail Lette served as the RAD-8 International Liaison to the World Health Organization in Geneva, Switzerland, where she lived for 7 years. Originally, she was a student of French language and literature at the University of Michigan, which is actually at my home. Then went on to get her MD from Mayo Clinic, and then completed a radiology residency at the Mayo Clinic Jacksonville. She has had many other roles with NGOs and United Nations bodies, and is a well-respected authority on concepts of radiation safety and international guidelines for radiation, especially how those are implemented across the globe. Dr. Mikhail Lette, thank you for joining us today. How are you doing?
I'm doing great. Thank you very much for this kind invitation, Nikita.
Well, first, Dr. Mikhail Lette, with the very exciting career path that you have had, I think our listeners would love to hear a bit about how you got to where you are now in Vienna with the IAEA. Would you mind giving us a brief explanation of your interests and motivations along the way and how they may relate to your current role?
With pleasure. I entered medicine with the goal to make a difference. And as a med student, I spent a month way back when volunteering in a hospital in Madagascar, where a little help went a very long way for individual patients whom I still remember. And that cinched it for me. Sometimes I even reread my old medical school entrance essay to revisit and reinforce my ideals. After practicing radiology for quite a few years at a regional hospital in Florida, my family and I moved to Switzerland. My husband's Swiss. We wanted our kids to be multilingual, and I'm now a dual American and Swiss national, which isn't automatic, by the way. Through RAD-8 International, I had the great fortune of being introduced to the WHO, headquartered in Geneva. And while working at the WHO, I was first introduced to the IAEA, headquartered here in Vienna, to participate in several initiatives to establish or improve radiology in low and middle income countries. For example, I remember a particular interventional radiology project, a particular project concerning the medical imaging needed to address women's cancers, lots of good work. And then when a staff position at the IAEA opened up this year for a radiologist, I applied through their rigorous international recruitment process. Ultimately, I was humbled to have made their short list of candidates, at which time I approached the US to seek their support of my candidacy through the mission and embassy here in Vienna, and I'm deeply grateful for that support. The IAEA is a UN agency. And then the IAEA offered me the spot and I eagerly accepted. So following years of various consultant contracts with the IAEA and with multiple non-governmental organizations, I'm privileged to have joined the IAEA this past July 1st as staff. And in this capacity, our IAEA team has the capacity to assist so many marginalized populations in so many countries. I'm in the Division of Human Health section of nuclear medicine and diagnostic imaging.
Wow, that's incredible. It's evident from your story that you have worked so hard to get to where you are now, and you have seen so much. And I'm sure that you have drawn some conclusions over this time as well throughout your experiences. Would you be able to provide us with an overview of how you have seen cancer imaging in the sphere of global health change over the course of your career as you've navigated through these organizations?
Oh, this brings back memories. From my medical student days at the Mayo Clinic, I keenly recall the era of radiologists interpreting thumbnail sequential CT images on film. The PET scanner was named by Time as the invention of the year in 2000, not so long ago. Now, cancer imaging without PET, more specifically hybrid PET, is unthinkable. And the dependence of TNM staging or radiotherapy planning upon PET is incontrovertible. So how have I seen cancer imaging evolve? A cancer patient now, in a privileged setting, has dramatically more hope than a few decades ago. It's a remarkable time for someone like you, Nikita, to be entering this field. We have so much more to offer. The advent of genomic profiling, targeted therapies, checkpoint inhibitors, precision patient-centered imaging like molecular imaging techniques and radiomics. These were not yet on our radar when I was a resident. I remember we compared CT images and PET images on separate workstations across the room, rolling our chairs between the two. But the innovative techniques I just mentioned are not available to most in this world, intangible for so many patients. The fight to extend the benefits of basic imaging modalities to most people is still on. Similarly, the IAEA, in delineating just how many countries do not yet have radiotherapy, we showed that many countries don't have a single unit, not one. So I hope I answered your question. I could speak for hours just on that.
Yes, definitely. I just love hearing about how our modalities have changed over the course of very recent history, and through your lens, this is even more interesting. You started to describe a disparity that exists among different countries across the globe. So I would now like to focus on how you believe cancer imaging has changed at the global level due to the work of different UN organizations, such as IAEA and the WHO, or professional organizations and NGOs like Rad Aid International. specifically in low and middle income countries. Can you please speak more to that?
Excellent question of particular relevance now. The COVID-19 crisis has shown a spotlight upon the importance of imaging in tackling a pandemic. The WHO and IAEA, partnering with each other and with professional societies, developed rapid guidance documents, webinars, many resources. And in the case of the IAEA, much procurement took place to support member states, whether RT-PCR units or even following the recent Beirut blast, the IAEA procured and provided X-ray units. But to get back to your question, in terms of cancer imaging in particular and the change at a global level, we have a few recent examples of work. The IAEA partnered recently with several institutions, Harvard, Memorial Sloan Kettering, the Olivia Newton-John Cancer Research Institute in Australia, and showed that simultaneous expansion of treatment, imaging, and quality of care could improve 5-year survival by more than 10 times in low-income countries and more than double 5-year survival in lower middle-income countries. We studied survival of 11 prevalent cancers in 200 countries. Statistics like this help UN member states and ministries of health in strategic planning, but so many more studies need to be done. A recent initiative near and dear to my heart was developing the IAEA Imagine database. If you Google IAEA Imagine, it's the medical imaging and nuclear medicine global resources database. And we showed, for example, that in high-income countries, 25,000 people are served by one CT scanner, but in low-income countries, approximately 1.7 million people are served by one CT scanner. Can you imagine the difference between 25,000 and 1.7 million? We are in the process right now of looking at the big picture. What do countries have? What benchmarks exist for what they need? There are no current benchmarks, for example, of optimal CT scanners per million inhabitants. Moreover, such benchmarks should be tailored to countries' epidemiologic profiles and other parameters. This is all translational research underway right now, and there is a commission upcoming, the Lancet Oncology Commission on Imaging and Nuclear Medicine, and stay tuned for that because much of this body of work will be in there. As well, we're doing work with countries so that there will be country progress monitoring, setting targets for them for imaging and moving towards those targets through technical cooperation, through, for example, the IAEA impact reviews, the Program for Action in Cancer Therapy. I could go on. The WHO is developing a costing and impact model for non-communicable diseases, and they have a work plan mechanism with non-governmental organizations, non-state actors like RadAid International, including cancer imaging. I believe you and I spoke about Asha Jyoti, the example in India, imaging of women, and a lot of work in terms of breast cancer imaging there. Going back to your question, RadAid in particular was founded in 2008 and now works in over 30 countries. And in terms of the potential for people like you to volunteer, there are many university chapters. Going back to my alma mater, the Mayo Clinic, I know the Mayo Clinic Rochester chapter was engaged in teleradiology for Haiti, and the residents presented that work, stating that not only did they bond with staff at the Mayo Clinic Rochester in doing this good work, but they also saw a different spectrum of pathology in Haiti, and of course they were able to help in Haiti. Similarly, at the Mayo Clinic Jacksonville, there was an interventional radiology initiative with Vietnam. So there is the capacity to establish chapters at various academic institutions as well, individual experts can volunteer, for example, in this virtual age by delivering webinars on particular topics within the realm of their expertise. So this question demands more time for a comprehensive answer, but clearly you can hopefully hear my enthusiasm.
Yes, definitely. Thank you for actually describing some ways that people like me can get involved with global cancer imaging initiatives. In particular, I really appreciate you mentioning that IAEA Imagine database, the medical imaging database, to look into certain statistics, such as how many people are being served by a single scanner. I did not know that existed. That sounds very interesting, just to be able to open our eyes to what the landscape really is like. Resources like this and the ones you mentioned being further currently developed by the WHO and Rad-Aid International may certainly be helpful to those who are interested in this type of work, whether they're trainees like me or at any other stage of their career. You are truly an inspiration, and you know I feel that way about you. And I would like to ask, actually, if based on your personal past experiences, do you have any advice for oncoimaging specialists or trainees geared toward that field who are interested in addressing cancer imaging at the global level as you have done?
You're very kind, Nikita, but I have to start by saying that I'm standing on the shoulders right now of many inspiring mentors. I had great fortune in working with so many incredible people. To go back to your volunteering question, in my humble experience, the simplest volunteering is through capacity building, teaching. For example, if low and middle income country facilities request improvement in certain topics, someone like you, even at the residency level, can deliver lectures virtually. Our virtual environment enables this, and through this COVID-19 crisis, the low and middle income countries too have learned how to use the virtual tools more, but building the bridge and coordinating who needs what, that's the difficult part. But it can be done through us as individuals, through working with NGOs. For example, in the cancer realm, the Union for International Cancer Control, also headquartered in Geneva, does a lot of this work. I mentioned the Rad-Aid chapters, and for example, throughout Latin America, they've worked with PAHO, the Pan American Health Organization based in Washington, D.C., to deliver many webinars. The UN agencies, it's true that individual experts are sought to participate in particular initiatives. In terms of work plans, for example, the WHO has FENSA, the Framework for Engagement of Non-State Actors, and it's through that mechanism that groups like the International Society of Radiology, Rad-Aid, the International Organization of Medical Physics, the World Federation of Ultrasound in Medicine and Biology, DITA, the umbrella organization of the health IT and radiology manufacturers and others relevant to radiology, they develop collaborative work plans with the WHO. And there's a transparency register of these. Anybody can look up their work plans online now. And it's just to make sure that in the tug of war to improve the world, that we're all pulling the same cords and in the same directions. I must say that it's an objective fact that very few radiologists work either for or with ministries of health, particularly in low and middle income countries. Seeing that the ministries of health strategically plan their country's health systems, largely without input from the radiology world, I think you see where I'm going, that not all low and middle income countries yet have professional radiology societies either. So from my perspective, having worked with multiple agencies, multiple NGOs, over the past 7 years, I see gaps like this. Low and middle income countries trying to improve radiology, they can't afford, for example, subscriptions to the highest impact factor journals or to attend the biggest meetings. But going back to COVID-19, it's really strengthened our capacity for conducting a lot of work virtually, using less money. Building radiology in LMICs, low and middle income countries, it's suddenly much more possible remotely at a time when the WHO estimates that medical imaging remains insufficiently available to over half of the world's population. IAEA Imagine now spells out these inequities, country by country, in an unprecedented way. And so much inspiring work is taking place. Bridging the gaps in radiology and nuclear medicine access for low and middle income country populations should be headlined alongside the latest, greatest technologies. And unquestionably, we can do a lot of this work together. Thank you so much for inviting me to this podcast. I'm restraining myself from answering these questions at greater length because there's just so much to be said. It should be prioritized next to all of the other articles and headlines in radiology. So thank you.
Dr. Mikhail Lette, you have certainly described essentially an open stage for radiologists interested in global cancer imaging. There are many opportunities I'm hearing to a degree where it is almost a necessity that we as radiologists get involved with public health at the global level, whether it is through education, even virtually. In this era, we are all becoming skilled in virtual education or working for different organizations. You mentioned the Union for International Cancer Control or International Organization of Medical Physics. Of course, all of the UN bodies, the RAD chapters, even you mentioned ministries of health in these low and middle income countries. I really thank you for your insights and sharing your expertise and knowledge in a very brief manner. I apologize for giving such a, but I think despite the limits of time, we have learned so much from you in these few minutes. And thank you again for taking time out of your day and joining us today. I think all of our listeners will really appreciate everything that you have to offer. So thank you.
I greatly appreciate the opportunity, so thank you.
We have some very special guests with us today. Dr. Onyi Balogun is Assistant Professor of Radiation Oncology at Weill Cornell Medicine. She is a nationally recognized expert in the radiation treatment of breast and gynecologic malignancies, and is a graduate of Harvard University and Yale University School of Medicine. Dr. Balogun completed her training at the University of Chicago and New York University, and joined Weill Cornell Radiation Oncology as faculty in 2015. Dr. Balogun grew up in the US after her family immigrated here from Nigeria, and her connection to her home country has played an important role in her professional development, as she will share with us in this interview. She has a thriving academic career as a researcher, clinician, and educator. Her most recent publications include a 2019 article in JAMA entitled Shaping the Path for a Global Oncology Academic Career, and an article that just came out a few months ago in the Red Journal, one of the most prestigious radiation oncology journals, entitled Radiation Therapy in Gabon, Multi-Institutional Collaboration as a Paradigm for Growth in the African Radiation Oncology Sector. I am proud to call Onyi not only my colleague, but also my friend, and we share not only a passion for academic medicine and oncologic imaging and therapy, but also the joys and challenges of parenting two young boys as a two-physician family. In fact, your two boys are just a little older than my two, and we first met in person at a kid's birthday party, which I find really cute because we had known each other for a while over email, but that's where we actually met, at a kid's birthday party. So, Onyi, Dr. Balogun, thank you so much for joining me here today.
It's my pleasure to join you, Jana. You're so you're just phenomenal, and I'm glad that you asked me to do this.
You're too kind. Thank you for sharing your time with us and your expertise. So let's dive right in. I'm sure our listeners would love to hear what motivated you to go into radiation oncology and to focus on global health as a vital part of your academic career.
So, as you alluded to, my being born in Nigeria, being born in an international setting, really contributed to me wanting to incorporate global health into my career. We left Nigeria when I was about 7.5 years old, and we came to the States. And a few years later, we learned that my father's only sister, who was also my godmother, had breast cancer. And she asked me to take pictures of her because my father hadn't traveled with us, and she wanted him to just see how she was doing. And when she revealed what was under, her outfit, I had seen a little bit of darkness on her neck. And when she, took off the dress to show me, it really left an impact. What I was seeing were side effects from radiation therapy, although I didn't know it at the time. She had traveled from where she lived hundreds of miles to another center in order to reinstitute her radiation therapy care. So she actually had to stop her radiation and resume elsewhere, hundreds of miles away from her children, because she needed the hopefully life-saving treatments, got radiation therapy there. So I took those pictures, and it really left a mark on me because they looked, painful. And from then on, I just decided that I was going to take care of cancer patients. And when she died, unfortunately, that really dealt me a blow and made me have this, thank you, it made me have this vendetta. I think I had a vendetta against cancer for a while. But I got to college, and it was always cancer. It was always global health. And that's really how I got into it. I think the second thing that solidified my interest in global health or global oncology, we call ourselves global oncologists, was spending a year in Nigeria after college. I fortunately ended up getting about 3 fellowships that sponsored my year in Nigeria doing breast cancer research with Dr. Funmi Olopade. And she took me under her wing and has been, advising me for the past few decades. And so I went to Nigeria, I did some breast cancer research, saw the facilities that she really set up that were really groundbreaking at the time. At the same time, I was working with a group called BRECN, the Breast Cancer Association of Nigeria. We were doing a lot of patient advocacy work. And so we would hold sessions to teach people, what should you expect in cancer care, just as kind of a means of giving information that they might not be able to get at their short visits with their physician. So I learned a lot during that time. And the one thing I will say that really struck me was patients would ask me to sign up their name, to put their name down on a list. Because I would go running first thing in the morning, and they knew that I would get up early. So they would ask me to write down their name on this list, because as the day goes on, the machine may stop, or the markers may end, or there may be something else that prevents them from getting treated that day. And the higher you are on the list, the more likely you are to get your radiation. So I'll never forget that kind of, grappling for resources, for health resources. So I'd say that, seeing my aunt and having that year off in Nigeria really set the stage for my passion for global oncology.
Yeah. And we're so lucky that you are here at Cornell doing this important work. But your mentor, Dr. Funmi, must be so proud of you.
She's great. She's wonderful,
And, I'm just sitting here listening to you, and it's so heartbreaking when I think about how privileged we are here, like how many radiation oncology centers with linear accelerators and everything are there in Manhattan alone.
Yeah.
And then in some countries, patients, like you said, have to travel hundreds of miles.
Yeah, I mean, it's something that I think about a lot. So right now on the African continent, just under half of the 54 countries have no radiation therapy.
Yeah.
No, and we're talking sometimes about millions of people who have no access to radiation therapy. And that's something that we have to change. Myself and my colleagues are working to change, because people frequently think about the surgery, they frequently think about chemotherapy, but there's a third pillar, radiation therapy. And there are a number of cancers that you can't talk about cure for without radiations. Locally advanced cervical cancer, the way we cure that is with chemotherapy plus radiation. And we know cervical cancer is one of the, most common malignancies in low middle income countries, because sometimes, we have a great screening program here in the United States, but that may not have been implemented in other countries. So we still have to think about radiation therapy. Head and neck cancers include radiation, lung cancers that are locally advanced. Chemo radiation is part of the formula.
So tell us a little bit more about the work you're doing to address these disparities.
There are multiple things that I do. The first is education. Education is very important to me. So one of the initiatives that we have implemented is called Chart Rounds Africa. So Chart Rounds is a website that was created by a radiation oncologist named Patricia Hardenberg. She works in Colorado, and she put together this resource for people in rural settings in order for them to have access to expert advice when they were putting together their radiation oncology plans. And this really took off, I think, around like 2010 or so. So she began creating sub-sites. So one of them was Chart Rounds Africa, and she gave me the opportunity to help lead this Chart Rounds Africa initiative. So what we do is we have radiation oncologists and clinical oncologists, really, from African nations submit their cases that they want some feedback on, because that's what medicine is, right? So Chart Rounds Africa has really been one of the main things that I'm involved in. And the other things that I'm involved in when it comes to education is just training on the ground. And what I realized in residency is that the technological leap that we made in the 1980s in the United States, low and middle income countries were just making it in the 2000s, the 2010s. They were just beginning to implement it. And I was thinking about, when you leap to another technology, there's a learning curve. And frequently, you want to make sure that, number one, you're using the technology appropriately, because with radiation, there's a lot to lose. There's a lot of risk involved in treating inadequately or giving too much dose. So I wanted to make sure that we had a way to teach people how to use these technologies. I was put in touch with a group in Armenia, and hi to my Armenia family. I consider myself partially Armenian. And so in 2015, I found myself on a plane, bringing some radiation therapy equipment to Armenia. And we did a 2-week course on breast cancer treatments. And they went from, hardly treating patients with the new technology to treating essentially every patient with the new technology. And, it wasn't just me going there, but I like to think that I helped as well. And so till this day, we maintain a relationship, and teleconferencing has been how we stay in touch. We also did this breast training in Gabon, but they were more interested in prone breast, treating breast cancer patients lying on their stomach, because that decreases the dose that goes to the heart, to the lungs. So I was able to go to Gabon. In 2018, I took a resident with me who just matched into radiation oncology and was interested in global oncology. Also took a Cornell University undergraduate and a radiation therapist. And the team of us went and did a 2-week course with the Gabonese physicians, because they were seeing more and more early stage breast cancers and wanted to see if they could incorporate prone breast radiation. So that's where, another relationship took off. And I've also been fortunate to work with individuals in Ghana and Nigeria. And I'm just really happy that I get to do what I do.
I think that's amazing. So do you try to, of course, now we're living mid-COVID and amidst the madness that is 2020, but one day, is your goal to basically go on trips such as the one to Gabon and Armenia on a regular basis and bring with you a whole team.
Yeah. So that's the right word, the madness that is COVID. So, I've managed to try and find the lemonade in these lemons, but I'm missing the travel. I try to go at least, twice a year. And then the rest of the time we communicate via teleconferencing. And I think that has actually given me a leg up in this COVID, because I was using teleconferencing a lot before. So it's my time, I'm not on mute usually on Zoom. I know when I'm on mute or I'm not on mute. So
you're the queen of Zoom.
I'm the queen of Zoom. I like to think I'm the queen of Zoom. So once COVID came, I was like, oh, this is nothing. I'm used to these teleconferences. I know the, advanced features to use, but I really do miss being able to go and connect. It's very important to me to go in person. It creates a relationship and a rapport that I don't think you can approximate using Zoom, but there's something different about meeting someone where they are. And that's been one of my key things. But as you said, what we're hoping to do is establish multidisciplinary cancer teams that will go to these sites and work with them. Because, for instance, if I just focus on radiation for breast cancer, what about the surgery? Is the surgery being done appropriately? Are they getting good margins at the time of surgery? What about the chemotherapy?
What about the imaging?
Or the exactly. What about the imaging? So one person who has done this really well and started is Dr. Lisa Newman here at Cornell. She is part of ICS, BCS, the International Center for the Study of Breast Cancer Subtypes. So she and Melissa Davis have worked for a long time on putting together cohorts of international breast cancer subtypes. So they have a long-standing relationship in Ghana, and I was able to accompany them to Ghana, so that while they are working on the research, the basic science research, and Dr. Newman is working on teaching the surgical techniques for breast cancer, I began teaching the radiation oncology techniques, or just, fine-tuning them with my colleagues in Ghana who already know a lot. But one of the things that sprung from that is a relationship with Dr. Shukla here in colorectal surgery. He's very open to traveling. So he and I were going to start, but then there was COVID. We were going to start an education program in colorectal cancer, because what we found was that when I was once there, I was looking at their list of patients for planning in the radiation oncology clinic, and I saw 38 rectal cancer. 25 rectal cancer, 42. There were just so many young rectal cancer cases. And we're seeing that too here in the United States, right?
Yeah.
So I was wondering, why are they seeing so many young rectal cancer patients? But talking with them, what I found out was that if they have low-lying rectal cancers, many of these patients, after they've gotten neoadjuvant, chemo radiation, don't want to go for surgery. They don't want to lose their sphincter.
Yeah.
For them to get there's a surgical technique that would not have them lose their sphincter, but that technique is only done in Accra, right? The main capital of Ghana. So they're just like, oh, no, thanks. I'll just go on about my way. I don't want to travel. I don't want to lose my sphincter. So Dr. Shukla and I had put together a proposal to teach people how to perform low-lying rectal cancer resections after radiation therapy. So the multidisciplinary aspect of things, but COVID hit and that's on pause. But those are the kinds of things that we want to do, not just, oh, I'm here in my silo, I focus on radiation, I'm going to just teach you about radiation. Let's bring the surgeons, let's bring the radiologists, let's bring the rad-oncs and the med-oncs, let's bring a comprehensive team together that can, help elevate all these aspects of cancer care.
I think that's really fantastic. And I guess that brings me to my last question. What can we here in the US and around the world, cancer imaging specialists and radiation oncologists listening, especially trainees, What can we do to support your important work? What are some ways for the oncologic imaging and radiation oncology community to get involved?
Wow. So if anyone is interested in getting involved, they should reach out to me. There are also other organizations. So RAD-AID, for instance, is one of the organizations doing a lot of great work. There are also institutions like the ACR. So the ACR will give awards, and Astro also gives awards for people in training to spend some time internationally doing global projects. So those are some of the things that people can do. And, of course, you can financially always helps, but I think one of the most important thing is the brain power, right? If you want to be involved in a session remotely, you don't necessarily have to travel in order to make a difference. Those are some of the other ways that you can get involved. There are multiple different roads that you can take.
That's really wonderful. And I'm sure you will be getting a lot of requests and follows and tweets coming your way, because
I welcome them all. I welcome
them all. It's really inspiring to listen to you and learn from you.
Oh.
So thank you very much for this interview. And I look forward to continuing to work together in the future.
Thank you for having me. It's been great.
This concludes today's podcast episode for Radiology Imaging Cancer. I enjoyed learning from this inspiring group of radiologists and radiation oncologists about the importance of not only providing the best possible care for cancer patients locally, but also taking on an active role in improving care for patients worldwide, particularly those in low and middle income countries. As we have seen, key factors are improving education, thereby improving access to training in radiology and radiation oncology for physicians locally, as well as overcoming financial barriers, providing the resources needed to offer advanced oncologic imaging and therapy. If you feel inspired to do more and get involved in global health initiatives discussed on this podcast, I encourage you to go on our website, where we have links to everyone's pages and Twitter handles for more information. I know all our guests and I myself would welcome continuing this discussion with you online and hopefully soon in person. Thank you so much for listening. I hope that you enjoyed this episode. We would love your feedback. Please subscribe on Apple Podcasts or wherever you get your podcasts and give us a rating to help more people discover our show. I'm Dr. Jana Ivanidze, and this is Radiology Imaging Cancer. See you next month.